Thank you very much, Ruth. That was an excellent introduction, and it is great to be back in Melbourne. Among so many friends and colleagues that we've met before along the way, and certainly the Women's Health Victoria crew, with whom, as you heard a few minutes ago, we did an extensive project on gender transformative health promotion some years ago, which resulted in that big, thick book called Making It Better. We're really pleased to be here today. We've got a few new endeavors going on, so the first couple of slides will tell you about that. First of all, I think it's important that I mention...
Sorry, I was just having withdrawal from my phone. It's been 30 seconds.
We have a new scientific board in Canada, of which I'm the chair, on health products for women. And we have just recalled in Canada Allergan textured breast implants and transvaginal mesh products from Boston Scientific. And I know this is highly relevant to what's going on here in Australia. I was so pleased last week to see the consumer group that had won such a victory here. But you know, these kinds of things are so concrete, but when you hear the stories attached to these issues and how long they've been going on, you cannot help but be recommitting yourself to the women's health issue in general, and to understanding the details and the ramifications of all of the various inequalities, whether they're in research, clinical trials, whether they're in advocacy groups or health promotion or anywhere else. I'm also a member of the board on vaping products in Canada, on e-cigarettes, and I can tell you that's not the place to be right now. We're having a heck of a time with that. But generally speaking, things are happening. Before we get into what's going on in Canada, though, Nancy will say a few words about herself.
I just wanted to say that Lorraine and I have had a lot of opportunity to work all across Canada with organizations at many different levels around doing critical thinking on sex, gender, and health. And it's been an absolute pleasure, and we really are looking forward to having the opportunity to talk about it here today. And I just wanted to signal to people that we did bring some of our last book that we did together with us, the Gender Unchained, Notes from the Equity Frontier, with us. So you're more than happy to, or you're more than welcome to pick out one of them and pay us $20 if you're able from the store outside. We also brought a lot of samples of other materials we've been doing around trying to create resources that are helpful to service providers, policy analysts, health system planners, and women advocates across the country. And we'll talk about a few of those today in the sub-sessions we're having this afternoon.
It's really important to know that we've worked a lot in substance use and mental health together. And in Canada, we always say mental health and addictions. It's one phrase. So that's part of the perspective we'll be bringing in our examples today and in the breakout sessions. But just a few updates from Canada. You might recognize this chap here. We've just had a general election, and Justin Trudeau, who was famous in 2015 for having set up the first gender parity cabinet in history. And when asked why, he said, because it's 2015. Well, now it's 2019, and he's done it again just last week. And I was so pleased to hear that you have one here in the state of Victoria. I think it's such a basic accomplishment and something that we're very proud of. However, he's been chastened in this election. He's got much less of a majority. In fact, he has a minority government. But the key thing that I want to talk about today in his mandate, he came in 4 years ago and he said, we have had a sex and gender-based analysis policy in Canada for 20 years, and it really hasn't amounted to much because not everybody has done it, including those within the government and those outside, and we haven't got good data. And when the Auditor General of Canada had a look at that policy and its effect, she clearly said, there's been some compliance, but even when there's been some compliance, nobody's reported it, or nobody's analyzed it. In other words, it was a wishy-washy thing. So starting 4 years ago, that changed. And I hate to use this metaphor, but I couldn't think of a better one. The carrot was replaced with a stick. And now, if you don't do a sex and gender-based analysis in Canada, you, if you're in government, won't be able to get your stuff through the Treasury Board to get your money. And if you're outside of government trying to get money for a project or a research project or anything, a program, you won't get that either. And you know what? It's working. So we have had a tremendous opportunity, and that's why we're here today, to start this discussion again. Some other things have happened in Canada. I was heartened this morning to hear the statement about Indigenous women and Indigenous people in Australia. We have, as you know, similar issues. We've just finished a massive inquiry into murdered and missing Indigenous women and girls. Thousands who have gone missing over the last 20 years in our country. And, you know, just the incredible exposure of violence and racism and the effects of colonization and the legacy that has left. And that has been a remarkable process. We've also had Truth and Reconciliation. I think we're a bit behind you in these matters, but that too has been a very remarkable process. And we also have in Canada a First Nations Health Authority, which is the beginning of the divestment of responsibility. And we're working on divesting child welfare. And I will say both federal and provincial governments, particularly ours in British Columbia, are leaders in this area in Canada. In the substance use context, you probably do know we've had cannabis legalized in the last year. We also have a public health crisis on opioid overdoses. And as I mentioned, we have e-cigarette use among youth in unprecedented numbers. Some notable dates: it's the 50th anniversary of the Royal Commission on the Status of Women in Canada, which raised 264 recommendations, none of which were on violence against women. So you think of where we've come from in our country. We've come a long way in that issue and a lot of related issues. 50th anniversary of the abortion caravan, when literally 10 women started in Vancouver in 2 battered up cars and started driving across the country, collecting supporters along the way, ended up in Parliament, changed the seats in the audience gallery. And that was the beginning of a huge movement. And it's the 30th anniversary this Friday, sadly, of the Montreal Massacre, where many women were shot in a university classroom in Montreal by a man who said, "I hate feminists." So we've had those significant things to consider. Today, though, we're going to talk about where we go from here. We're going to talk about sex and gender concepts and skills, because we can never talk about that enough, as you can see by my first political example. We're going to talk about how sex and gender interact in substance use and mental health. And then what we're going to do is talk about some gender transformative responses, because that is where we're at. We're interested in equity at the end of the day. We're interested in recognizing diversity among women and between women and men and gender diverse people. And we're interested in figuring out how to build skills among ourselves and our communities in that regard. So here's a poster from the Canadian Institutes of Health Research. We now call ourselves, as researchers in Canada, sex and gender scientists. And I'm going to say that again, sex and gender scientists. That speaks directly to some of the comments made already today from the audience about missing pieces, not only in research subjects, but also in researchers getting perhaps differential amounts of money. But it also speaks to the whole notion of the importance of sex and biology along with the importance of social issues. And that's what this poster really talks about. But you know what? The more we do, and this is why we need to think again, the more we realize that we don't know what we don't know. I'm going to say that again, too. We don't know what we don't know. That's how bad it is. We review evidence all of the time. We also contribute as researchers to building evidence. And we are continuously shocked by the gaps and vacancies in the evidence where key questions have not been asked by separating even rudimentary segregation of data, let alone reporting and analyzing. So how does it matter? Well, we have bodies, and when we're born, they have certain characteristics, and I've listed a few here, and we cannot ignore them, especially in the field of substance use and mental health. I'll just give you some basic examples. When you inhale something into your body, it's got properties in it, and the kind of body you have responds to that in a particular way. So we know, for example, that if you inhale nicotine, as people do, or if you drink alcohol, as people do, that has an effect on you that's different depending on your hormones, your size, your weight, the amount of fat you have in your body, your physiology, your genetics, your chromosomes, etc. So we can't really escape that bit. And then society. This is really about the gender part. This is much more fluid, much more complex, much more evolving. It's different in different places, contexts, cultures, and it changes over time. But it is about a bunch of things that, again, we need to get into and name, and that is gender roles, norms, relationships, the power imbalances between genders, and our gender identities. And that all has an effect, too. And as I said, there's loads of gaps. So a little bit of a lecture here. When we talk about sex, we're not just talking about that checkbox on your birth certificate. We're talking about all of these things. And I've just done this diagram to talk to you a little bit about how these things matter. And, you know, they change over your life, too. Your sex hormone production changes as you age, for example. And it turns out that has an effect on certain things, as we might expect. Your anatomy changes, etc. So we've got lots of things here that are not exactly fixed, but they do matter and they do need to be measured. We've created some very basic pamphlets among many of our knowledge products that just simply list these things, and they're all available for download on our website. So these are pretty basic things that you can use as a practitioner, or you can hand to a woman and say, listen, if you take alcohol or tobacco or cannabis, or if you take prescription opioids, here's some things you should know. And these are all sex-related. We cover women in general in terms of women's health. We also cover pregnancy, breastfeeding, and parenting. Gender. Again, a little lecture mode for a second. Gender is not just one thing. It's all of these things. Our performance, our gender identity, whether it's masculinity, femininity, issues around transgender identity come up here. But our gender roles determine our opportunities, and our institutions are gendered still too. And that's what sex and gender-based analysis is meant to analyze and try and repair. I liked the example this morning, actually, about snow plowing in Sweden and how that is a gendered effort and has gendered impact. As a person who broke my ankle in Sweden, that really rings true for me. And we really do need to think through how our environment, our budgets, our rules and regulations all have differential impacts on women and men, girls, boys, and gender diverse people. And gender relations are all about those decision-making, a bit more amorphous stuff, but you know, it's the reality of our daily lives. You walk toward the car with your boyfriend, who gets in the driver's seat? Is that ever discussed? You know, that's just a minor example, but these are things that we swim in. This is the water we swim in. And so gender and sex interact, and that is really the key thing that makes this field so complex. And that's why we're saying think again today. It's not just gender and a kind of amorphous or simple understanding of that. It's not just sex, same thing. It's all the components of sex, the components of gender, and then, just to make it more complex, how they interact with each other. For example, we have just learned, because researchers are beginning to ask these more complex questions, that for women, having childhood trauma actually affects the symptoms in menopause that you might experience. Well, who knew? And there are biological reasons for that. So, you begin to think, well, that could have an impact on my practice, or that could have an impact on the health information we might want to give women, etc. And gendered exercise, it's an old example, but a good one. We have patterns of exercise that are, perhaps more approved for men or approved for women. It actually literally affects the development of your bone and muscle health. So, setting you up for different diseases and conditions. And then just to add on even more complexity, we have intersectionality, which reminds us consistently to think of the differences among women, among girls, among men, among boys, etc. And not only thinking about the characteristic differences, but rather the huge ocean we're swimming in with all these processes that we've already mentioned today about colonization and discrimination and marginalization, about stigma, about geography, sexism, classism. By now your head should be swimming. How do we measure all this? Well, one of the things Nancy and I have always done is to say, look, what are we trying to accomplish here? We could get all hung up in these concepts, but what we really want is equity at the end of the day. So this is just our perhaps simplification of it all. But we need to consider all of these things in order to keep our eye on the ball and go for equity. And we think it matters to look at lived experience and do qualitative research when necessary, do subpopulation analyses. I'll give you an example. In both our countries, we've seen the tobacco use rate drop drastically in the last 20 years. And if you're kind of in public health, you often run into the idea that, oh, that's great, we've solved that problem. But if you actually look at the subpopulations of who's smoking now, you'll see we haven't solved that problem at all. We've got 5 or 6 new ones because they're particular groups with particular issues that we ignored when we just did high-level analyses. And so then we can set ourselves up to actually respond better. So sex and gender-based analysis plus reflects all of these things I've just mentioned. And we are very careful to say sex and gender all the time, because we are very interested in making sure that all of us remember that these are interactive effects at the end of the day, and that we should, in many ways, be educating each other about all of these aspects of sex, gender, and diversity, and really committing ourselves to this way of thinking. And in Canada, as I mentioned earlier, it's a commitment that now gets you funding or doesn't get you funding, and that has turned out to be an absolute gateway to a flood of new research, a flood of new programs, and a flood of new policies at the federal level and in some cases. So this is just an example. We're not really checklist people, but this is something we created just for a national organization last week on substance use. And we're sharing this too with the national organizations on mental health, just how you would do and make sure you had done a sex and gender-based analysis in these fields, because it's taking a lot of diplomacy and it's taking a lot of work to actually go into various sectors to say, look, guess what? But I must say, this work is so much easier now because they're all putting their hands up. A lot of organizations saying we can't get any money unless we answer these questions for the federal government. Can you help us? And we'll say we're happy to help. And that has been the opening that many of us have wanted.
We've never been busier.
Never.
So I'm just going to give a few examples of how sex and gender matter in substance use and mental health. And then we'll come back to Lorraine to talk a bit about gender transformative approaches. So this is a framing of how sex and gender matter in mental health and substance use that was developed many years ago by the NIH in the US when they were making a call for proposals. But you can see that they talk about sex-related mechanisms that Lorraine has already mentioned. They talk about gendered impacts, and especially important from our point of view are these prevention issues about gendered pathways, sex and gender-related risk and protective factors, the progression of problems, etc. So you can see there's lots to think about. The treatment issues, differences in responses to treatment and readiness to treatment, outcomes of treatment, et cetera. And then, of course, the whole area of reproduction, where there was a lot of attention early on at the expense of all these other related issues in sex and gender. So Lorraine alluded to this earlier, but this slide shows how Canada's low-risk alcohol drinking guidelines recommend differing levels of daily, weekly, and at a sitting alcohol consumption for men and women based on sex differences in the metabolization of alcohol related to anatomical size, body composition of fat and water, etc. And we particularly like this poster that was developed to advertise the guideline recommended amounts from Quebec with the number of recommended drinks above the woman's head and the number of recommended daily drinks above the man's head. And the statement is not sexist, it's science, right? So we thought it was a great response on their part. Now, this slide brings in the gender influences in substance use, and this is an intervention drawing on gendered motivations for quitting smoking. And you can see that it's especially targeted towards drawing on men's roles as fathers as a motivation for reducing or stopping their substance use, a program called Dads in Gear. However, substance use and mental health responses often ignore gender inequity, as we've seen, and they do this in two ways that we've noted here. First of all, by only discussing generic groups of people, and we often see, youth as a group that's talked about in substance use, et cetera. And really, we've given an example here of the lack of women-only withdrawal management programs, ignoring the impact of gender-based trauma and violence and not creating a safe space for women as they're withdrawing from substances. And the second example of ignoring the root issues and inequities is in the kind of superficial analyses that happen. And the example there we've used is the lack of childcare in residential treatment programs really preventing women's participation or their staying in treatment. So now we're going to turn to the mental health interactions around sex and gender in mental health. And this first slide talks a little bit about the sex factors in relation to depression, and talks about how women have 2 times the depression prevalence than boys and men, beginning in adolescence, and that this is very much related to sex hormones, which affect depression for both men and women. And as Lorraine alluded to, that thing about sex changing over time, that this gender gap in depression narrows in adulthood. And that this is really not related to equity issues, from this study by Salk, et cetera. Do you want to say anything more about that, or?
Just that this is an example. These people looked at all the literature all over the world and did a meta-analysis, and they were interested in knowing if these sex differences in depression actually reflected gender gendered factors in various countries. And that's what they found, that no, they don't, that there was virtually no relationship to countries with better gender equity or worse gender equity. So it, you know, it raises a lot of interesting questions about the biology, essentially, of depression and the incredible health burden in a country or a state of depression when it's twice for women than what it is for men.
So turning to mental health in the gender side, this slide points to trauma in the form of sexual assault as a root issue and determinant of women's mental health. And really talks about how our response can be in this one paper from the US, I really like the title of, Trauma-Informed or Trauma-Denied, in the way that we respond. And this is a walking group, which is, I see as a gendered response to women who are marginalized by poverty, mental health and substance use issues, and racism in the downtown east side of Vancouver, a very poor neighborhood of Vancouver. And this walking group began with walking as a mental and physical health intervention. But over time, they really found it to have many other benefits, such as fortifying relationships and friendships between women and their connection to the community, and even the sense of, for the Indigenous women, this kind of reclamation of land by walking freely in a really dangerous and poor area of Vancouver. I included the picture of them all with their tank tops here because one of the things that this intervention did was it provided running shoes and tank tops for all the women because they didn't have the money to afford quality runners. And I just think it's such a beautiful picture of them showing them off so strongly. We have a new booklet out that we brought some samples of. It is directed at child welfare and substance use service providers. And it looks like this. And it's based on research about stigma, and that's experienced by mothers who use opioids and, you know, really all the interventions that have been developed to look at wrapping care around mothers and children where the mothers have used opioids. And in it, we offer an exercise that describes a similar situation of two women with different locations in terms of poverty, education, et cetera. And we invite providers to think about their responses if these two very different women came in to their services. So the whole toolkit is really oriented around encouraging critical thinking amongst workers about how they can be more gender responsive. And finally, as an example, I just want to mention this other toolkit that we did, and we continue to work with service providers, health planners, and policy analysts in substance use services and governments across Canada on how they might fuse trauma-informed and sex and SGBA plus approaches in the substance use field. And we've had a tremendously interested response from these governments and agencies across the country. And I'll talk a bit more about this in the session on trauma-informed approaches this afternoon.
So we're just going to tie this up by talking a little bit about gender transformative work, which is our passion, as a solution to some of these, what we often call in Canada, wicked problems. You know, when you think about mental health and addictions and the vast overlap between the two, depending on how you measure it, whether you're measuring mental health or mental illness or diagnoses or use of services, it's a Venn diagram. And the third Venn diagram, the third circle in the diagram for us is trauma, because that's connected to both. Hence the breakout groups this afternoon, where we can learn more about these overlaps. So we do talk about them in one breath, but as I said earlier, the vast majority of our work is focused on how do we do gender transformative work, whether it's health promotion or whether it's programming or whether it's policy making. And how do you actually integrate sex and gender, which is, in research terms, a commitment to transdisciplinarity. Because when you think about it, a lot of and I think one of the speakers this morning in the audience mentioned this, trying to make this jump between disciplines or between fields is tricky, because a lot of our universities and professional associations have you identify with a discipline, have you identify with a profession, and never the two shall meet or the five shall meet. Well, this entire book that I'm showing you the cover of here, called Transforming Addiction, we did to try and crack through that mess. Because if there's one subject, it would be addiction and trauma and mental health that is complicated. It requires thinking and analysis from every single discipline that you can possibly think of to give us insight. So that's why we are saying, in the background, we want to see some transdisciplinarity. One of the things that we have tried to do consciously in our work in this area is to bring in thinking from all of these sectors. Public health research, for example, the ACEs study, which you may know about, the Adverse Child Experience Study, very famous study out of the USA, which clearly linked adverse outcomes like substance use and addiction and mental health diagnoses to early adverse child experiences. And that has really, in many cases, revolutionized thinking in public health. Feminist scholars who have made these links between trauma in particular and addiction and mental health. And, come back to us through making recommendations that say, let's repair relationships. Let's repair issues like alienation and isolation. As a way through, and I think the walking group is a really interesting example of that, as a way through to solving some of these, what are often seen as medical problems. Indigenous scholars, there's a book here on the picture, Decolonizing Trauma Work by a scholar in Canada, which has proven to be very important to us. And a lot of our projects actually work hand in hand with Indigenous communities on trauma, on mental health, and on addiction. Because as we all know and have heard today in a couple of different ways already, the sources of those legacies and the legacies of ill health are longstanding and quite historical. And we have a thing that we've done a little bit of called two-eyed seeing, where we have fallen in with overtly and consciously melding what's called Western science with Indigenous wisdom and Indigenous science and knowledge. And that is called two-eyed seeing. And then, of course, neurobiology research we've already referred to. If we want to go forward and ignore basic science and ignore the sex-based aspects of our work, we're missing something big. So gender transformative approaches strive to examine, as you know, and change some of the underlying issues. And you know what? This is something we always say to practitioners. This is a choice. We can be gender blind, and much of the world still is. We can be, just keep our head in the sand if we want and not bother with any of this. Or we can be gender sensitive and gender specific, which is where most of us in this room are probably at. Or we can choose to do the heavy lifting and say, what are the root causes of some of these wicked problems, and how are we going to solve those? And so here's a bit more detail on that, because what we propose to you is that if we want to be gender unequal and gender blind, we are actually potentially exploiting gender stereotypes to keep people in their slots, whether they're men and boys, girls and women, or gender diverse people. If we do gender sensitive and gender specific word, we're accommodating those aspects, and that's a step in the right direction. But addressing the causes of these inequities is the truly transformative work that, as I said, is the heavy lifting. This is an example of the YWCA in Vancouver, which has tried to look at gender and mental health and violence and trauma from a gender transformative lens. And do you want to say a couple of words about this? It's a great project called Culture Shift.
Yeah, it's called Culture Shift, and they're coming through looking at the sexualization of women and girls and the corresponding masculinization, it's a major word, of men and boys, and really talking about how this is linked to unhealthy relationships, mental health problems, and a societal tolerance of violence against women. They have some amazing work on the site that I know parallels a lot of the great work that's been done by Women's Health Victoria as well, of really bringing together these complex issues and approaching them in a gender transformative way of trying to question the norms and relations connected to the way we're socialized as girls and boys.
So here are just some examples of where you can sit on this continuum. And, you know, we've got lots in the Making It Better book. We've got more in this book. And we're spending the next couple of days, luckily, delving into this way deeper and thinking about what is the next frontier in gender transformative work. But you may recall, and they're still around, unfortunately, but some of the original health promotion to get girls to not smoke cigarettes were basically just exploiting old gendered stereotypes and tropes. You know, if you smoke, you'll be unattractive to your boyfriend, or he won't want to kiss you. Well, I don't think I need to tell you what's wrong with that, but, you know, these things persisted for some time. And I remember having a very, you know, civilized argument with some people in the UK who had a massive campaign that was just about that, about kissability. I kid you not. And I said, and they said, well, listen, Lorraine, we can show you the data. This campaign worked. And they whipped out all their data. And I said, well, you know, okay, I said, but do you want to be responsible for making that work? And, you know, was well before we had words about gender transformative stuff. But I knew there was something wrong with this picture. And it really is a call when we do GT, gender transformative work, it's a call for all of us to do a little bit better, reach for a higher bar, think about whether or not we want to be part of the promulgation of things like that. Boys not being included in clinical trials, well, we put this here on purpose because usually it's girls and women not included, but, you know, we can see that that's pretty gender-blind stuff. Detox programs we've talked about, and programs to prevent fetal alcohol spectrum disorder often focus on women without thinking through the men in the context, and without actually addressing the male partners and getting them to take responsibility, we're not doing transformative work. So, as we said at the beginning, sex and gender still matter in women's health. We've talked about SGBA+. We cannot forget those skills. That's the basic toolbox. And in Canada, we're very happy to be able to say after 20 years of using those tools and getting nowhere, we finally built a house that is actually accommodating all of these issues around sex and gender to the benefit of all Canadians, in fact. And we've given you some examples of substance use and mental health and some others in GT. So here's what to consider as we go forward. How does sex and gender matter in your work? It's worth thinking about because you might just be thinking about one or the other to date. How do sex and gender matter to men and masculinities, which we're going to hear about now? And where does your work fit on the gender transformative continuum? And last but not least, the reflection panel today is going to include the 4 quadrants, as we call them, of engagement that we use in every single one of our projects. We don't go forward without having some input from all of those 4. So we consider that very important as well. Thank you very much.